Hello, my name is Yongxiang Yu. My project title is Fall Prevention Teaching. My clinical site is a big hospital surgical floor. Most of my patients come to the floor for the joint replacement surgery, like knee replacement, hip replacement. Some patients, they come here because of diabetic complications. They need surgery like I&D or toe amputation or below the knee amputation, etc. A small part of patients, they come here because they have hernia. They need to fix it, like a ventricle hernia. My learning goal is to teach this high fall risk group of patients to prevent fall, decrease the in-hospital fall rate. My learning objectives is to quickly identify fall risk factors for the individual patient, tailor the fall teaching plan to individual patient according to each patient's condition, improve my clinical skill as well as communication skills. How do I accomplish these objectives? With the help of my preceptor, first, I use the Baptist Fall Risk tool to assess each patient. Anyone, if their fall score is greater than 12, they fall to the high fall risk group. They are my teaching targets. The other criteria I use is any patient, if they have a fall within the last month or they have lower extremity surgery during this hospitalization, they will automatically fall to the high fall risk group. They are also my teaching targets. After identifying this high fall risk group patients, I use the fall prevention teaching sheet as my guideline to teach them. This is my fall prevention teaching sheet. Before the project, I also did the research. I googled I did some literature review. The literature showed that fall incidence is high in healthcare facilities. For the special group of patients, like the lower extremity surgery patients, the literature showed that the overall patient fall rate is around 15 in 1,000 patient days in the patient who undergo the knee replacement surgery. Another research showed that total hip replacement patients were at highest risk of falls leading to serious injury, and the total knee replacement surgery patients, they are the most commonly associated with falls. Comparing to my patient group, my patients, they undergo the lower extremity surgery, neither the hip replacement or knee replacement or toe amputation or below the knee amputation. They all go through the lower extremity surgery. The other character of my patients, they are very old. Most of the joint replacement surgery patients, they are in their 60s or 70s, some even in their 80s. So they are very old. The other character is the hospital stay is very short because the joint replacement surgery is a selective surgery. Most patients, if they have no complications, they stay here only for 3 to 5 days. Some patients, they only stay here for 2 days. The first day, they have the surgery. The second day, after the PT walks with them and doctor check them, they are discharged. So it's a very short hospital stay. Because of these characters, my patients fall to the high fall risk group. After interacting with the patient and practicing in that unit, I found the best practice in that floor, in that unit, is that every step have the fall prevention concept in their mind. They almost said every patient either in bed alarm or chair alarm. Except the characters I mentioned before, my patients also have these characters. Most patients, they have lots of lines connected to them. Because no matter the knee surgery, hip surgery, or the amputation, they are big surgery. After the surgery, the patient has IV lines. They need IV antibiotic. Because it's the lower extremity surgery, the lower extreme surgery patient, they have high incidence to develop deep vein thrombosis. So every patient has the SCAS, the systematic compression device to prevent DVT. Because it's big surgery, almost every patient has the drains. In order to prevent pain and swelling, in order to reduce pain and swelling, most patients have the ice pad. The ice pad is connected to the cooler. They also have lines. Some patients, they need oxygen. They have the nasal cannula. Most of the patients, they have either 4 or 5 lines connected to them. For the joint replacement surgery patients, because they are selective surgery, most of the patients, although they had pain before surgery, they still can't walk. Because of the short hospital stay, they didn't notice after the surgery, they don't notice they are connected so many lines. Some patients, if they want to reach something, they just stand up and go. That's put them on even higher risk for fall. That's why almost every patient has either bed alarm or chair alarm. I think that's the best practice in that unit. By interacting, communicating, and teaching patients, I found that patient education is the first and a very important step to prevent fall. By communicating with the patients, I found that most of the patients, they have no this concept about fall prevention. Because they have very short hospital stay, they have no time to, most of the patients, they have no time to learn this concept. Maybe that's why research found that even as a single intervention, patient education may decrease fall rates. I use the fall prevention teaching sheet as guideline to teach them. I teach them about the hospital environment, explain to them why do we set the bed alarms, explain to them why do they need to wear the non-slippery socks when they are out of the bed. I also explained to them research found that elimination-related fall comprise the majority of falls. Explain to them why do they need to call for help if they want to get up. After all the explanation, one time, one patient said, "Oh, my wife went to bathroom with bare feet, slipped, and broke her hip and hospitalized. It's a tragedy." The patient added, "I will definitely remember what you told me. I will bring this sheet to home, put it on my refrigerator as a reminder." I also encouraged the patient bring the sheet to home as a reminder. Most patients appreciate of the teaching. By interacting with the patients, I found that patient education is the first step to prevent fall. During my stay in the unit, no patient fell during that period. I found that patient education is the first step and a very important step to prevent patient fall. Patients only know this concept, know how to prevent it, and know the consequence, they will follow your instruction. As research pointed out, empowering patients to become active participants in fall prevention during hospitalization could be the answer to prevent patient fall. These are the references I used about my clinical project. Any questions? Thank you.